For us to make clinical studies.
Hello and welcome to Washington Post Live. I'm Frances Steed Sellers, a senior writer here at the Washington Post. Today we have two segments about the coronavirus pandemic, the lessons learned and what they mean for the future. So please stick around for both of them. First, I'm delighted to welcome Alexander Arwady. He's the CEO of the biotech giant Genentech, and he'll be talking to us about the scientific breakthroughs in medical science. A very warm welcome to you, Mr. Arwady.
Thank you very much, Frances. Pleasure to be here with you.
As always, I'd like to reach out to our audience and let you know to send questions to our Twitter handle @PostLive, and we'll try to get to a couple of those during the show. That's @PostLive. Tweet your questions. And before we start, a quick disclosure. Alexander Arwady serves on the board of directors of Pharma, today's sponsor. And now over to you, Mr. Arwady. I'd like to ask, first of all, about your treatment, Actemra, which received FDA emergency use authorization about a year ago, I think. Please, could you tell us who it's for and how it works?
Yes, absolutely, Frances. Well, this is part of our response to the pandemic. Very early on, we realized it was very clear to us that this is going to require mobilization on an unprecedented scale across the entire healthcare ecosystem. And our responsibility as a company focused on diagnostics and therapeutics was very, very clear. And we rapidly started developing diagnostics, and those diagnostics from Roche have been really a pillar of the response to the pandemic. Over 1.2 billion tests being delivered to help treat, or I should say, identify COVID rapidly. On the therapeutic side, which is Genentech's focus, we worked on 10 medicines, developing and researching 10 medicines for COVID. Two of them ended up with emergency use authorization. One is antibody cocktail in partnership with Regeneron, and the other one is Actemra or tocilizumab, which is the medicine you mentioned. Tocilizumab emergency use authorization is for hospitalized COVID-19 patients, and it's been shown to work in a very large study based out of the UK to prevent the risk of progression to ventilator and death in hospitalized COVID patients. So it's an anti-inflammatory drug, and it works in that sort of dramatic inflammatory response that patients, the most severe patients, can get. So it is by no means a treatment for everyday COVID. There are other options, but for the seriously sick patient, it's an extremely important part of the armamentarium that healthcare professionals have worldwide to treat COVID. And since the start of the pandemic, more than 1 million patients globally, hospitalized patients, have been treated with Actemra. So it's played an important role.
And that brings me to a key question about it. With the virus changing, mutating, evolving rapidly, and we've got new subvariants at the moment and the potential, of course, for new variants coming, will your drug have to change, or will it stick to its efficacy, whatever we see coming ahead?
It's a great question, Frances. It's not an antiviral, it's an anti-inflammatory, so it works on part of the disease pathway, and it should work regardless of the variant. If the patient goes into this immune dramatic acute immune response, then Actemra is one of the treatment options that healthcare professionals can use, regardless of the variant.
So you talked about this drug being available widely around the world, I think in 16 countries. That leaves an awful lot of countries that aren't getting it. What kind of steps are you taking to make sure that it is available globally?
Yes, well, our first priority as a manufacturer, apart from obviously the research and development, is manufacturing, and that was our very clear priority as we worked in parallel to determine, does this drug have a role in reducing mortality and morbidity in COVID-19, was to scale up production at risk. Again, before we actually knew, does this work or not? We actually devoted our largest manufacturing plant in the world, biologics manufacturing plant in the world, to COVID-19. So we moved all the other products out and focused on the production of Mrna and the antibody cocktail, and produced as much of it as we possibly could. I mean, this was clear to us that this was really critical for us to do. So first and foremost, that's what we've been seeking to do throughout. Is make this available as broadly as possible. It's very much a partnership with governments around the world to make it accessible. It is a drug that was already available and approved for other indications. So that represents both an opportunity and a challenge from an access standpoint. So again, partnership was really critical with governments.
I'd like to ask about another aspect of equity and access. We've heard so much about distrust, and the pandemic has done an awful lot to highlight the terrible inequities in access to drugs. One area that companies can have some control over is clinical trials. What is Genentech doing to make sure that a diverse group of people sign up for those trials?
Francis, I'm glad we touched upon this. Unfortunately, this is one of the really tough lessons, but if there's a silver lining coming out of the pandemic, it's shone such a stark, bright light on the issue of health equity that I think that we're now resolved as a whole healthcare ecosystem to make really needed progress here. I mean, in times of stress and crisis, equity issues are exacerbated. They existed already, but there was such a clear issue during this pandemic. We could see the mortality and morbidity was different, but we could also see that the access to care was different amongst these different populations. So during the pandemic, we were already working on the topic prior to the pandemic, but I would say the pandemic accelerated our efforts. And with the drug Mrna that we've just been talking about, we realized that it was going to be critical for us to answer the question, does this drug work not only in the broadest population, but does it work in underserved populations that weren't represented in the original clinical studies and not necessarily represented in some of the research that was being done during the pandemic. So we actually dialed up a study in short order focused on underserved populations, and we were able to recruit 85% of that patient population amongst underserved communities. That's the Black population, Hispanic, Latinx, and Native American population. In fact, the largest recruiting site was on the edge of the Navajo Nation, which I'm proud of, but at the same time, really speaks to the unmet need that the study recruited so rapidly within that community.
And what about pregnant women, another group that is often omitted from trials and about which there's very little data?
Yes, that's a very, very good point. I mean, that continues to be a challenge in terms of developing safe and effective medicines and making sure it's representative. Those studies are representative of the populations that need them. So, it tends to be that data comes out afterwards, after you've really established the safety in the broader population, and use of registries and real world data to really understand the safety of profile of drugs in that population, just like many others.
A question about supply chains. They're affecting all of us in all sorts of different areas. What sort of impact are they having on your work?
This has been one of the issues during the pandemic, and I think one of the calls to action to all of us is we've got to work more effectively together in partnership with governments in a coordinated global way to make sure we don't face the supply chain issues that we face during this pandemic, whether it comes to medical supplies or whether it comes to vital medicines or diagnostics. We have to work on this together. We certainly faced challenges during the pandemic with availability of key raw materials and our ability to continue with research and development of our existing portfolio of drugs, which are in critical areas such as cancer and neurodegeneration in neuroscience. These were really challenging issues. So yes, we have to make sure going forward that there's free movement of critical medical supplies, finished goods, and raw materials. We need a national policy which is really looking at a risk assessment approach and looking at this as from a national security standpoint, but working in partnership with other governments together to make sure that there aren't issues with border controls during an international health emergency like this one.
Yeah, so talking about a public health emergency, it thrusts a company like yours into close contact with the federal government. Tell us about how you worked with the government in getting Actemra accepted for an EUA, and whether that regulatory process you feel is encouraging of innovation.
The partnership with the federal government has been, overall during the pandemic, has been extremely positive. The level of public-private partnership, a sense of urgency, the responsiveness to key issues was really exceptional. And I'm hoping and expecting that we can continue this momentum coming out of the pandemic as we try and address all the many diseases which continue to plague mankind. So the partnership has really been excellent. I mean, we as I mentioned, for example, we dedicated one of our manufacturing plants to COVID. That required a huge amount of work, and a process that would, prior to the pandemic, would take over a year, we were able to do in a matter of months. And I can honestly say that we wouldn't have been able to do that without the partnership, particularly from the FDA. It's been extraordinary during the pandemic.
So we've seen this huge drop-off in numbers, and again, we're beginning to see maybe them picking up in certainly in hospitalizations and just maybe even in deaths. Vaccines have been shown to wane in efficacy over time. Are you surprised by the continued need for your treatment? What do you see going ahead for this kind of treatment for severely sick people?
I'm not surprised. I felt from the very, very start, and I by no means have a unique perspective here, that this was going to take testing, vaccinations, and therapeutics, the combination thereof, to be able to manage through this pandemic and get us through to the other side. And unfortunately, we're still not through to that other side. And it's very, very clear that we still need improvements in the vaccines. It's been really incredible that we so rapidly got very effective vaccines, but there's still room for improvement on that front. Testing continues to be really critical to have highly accurate, rapid testing that's easily and accessibly available to people. And then effective therapeutics. And we've also come a long way there to have oral therapeutics that can be taken at the first sign of symptoms for high-risk populations. But there's still room for improvement on all those three areas. So unfortunately, I'm not surprised. This is going to continue to be an area of focus for the research-based industry. Is going to continue to push forward in all these three areas and improve on what we've already got.
So I'm wondering if you have data on who are now getting the vaccines. Are they largely unvaccinated populations, or as the vaccines wane in their efficacy, is there high demand among people who are already vaccinated?
I don't have the data on the vaccination rates right now. We're primarily focused on the diagnostic on the therapeutic side. So probably your next guess is probably.
I misspoke. I'm sorry. I was asking about demand for your drug, which is for very sick people. Do you have data on whether that's being used largely by unvaccinated people, or for
We
unvaccinated
don't.
people?
No, we don't have the data to tell us as to whether it's used in the vaccinated or the unvaccinated population. I think it's an educated guess to say that hospitalized patients, I mean, that's the majority of the patients using our treatment. As we know, the data suggests that the majority of the hospitalized population are unvaccinated. So whilst I would like specific data on that, being a science-based company,
Right.
I think that's a pretty safe guess that they're unvaccinated populations, the majority of people who are receiving our therapeutic at this point.
Well, I don't think any of us thought we'd be where we are now 2 years ago, but looking back and thinking about how your company adapted, and of course you're talking about the huge changes you made to dedicate these resources to COVID, is there something you wish you could have done differently or did do differently?
I think overall, I feel like we moved at a huge sense of urgency, and I'm really pleased with the degree of partnership, both with government and with the private sector. I mean, we're partnering with people we never have partnered with before, and I think that's made a tremendous difference. I think, I would say that the topic of health equity, bears a heavy burden on all of us, and I think that we should have, and as a company and as an industry, we should have done a better job with regard to trust and equitable access prior to the pandemic. We're working very, very hard and fast to try and resolve those issues now, but that's something that really that does cause a lot of reflection and lessons learned. That we saw such a disproportionate impact, and what could we have done sooner? For years, again, we knew there were issues. We should have done more.
So you've had this relationship with the federal government, but of course, so much delivery rests on state and local officials. The public health service here is so divided among very small agencies, and we're going to hear from one of them in a moment. But how has that affected your approach? Is there a way you could have drilled down more effectively locally, or at least at the state level around the country?
We have a good relationship with many different agencies, but you're right. This was a complicated tapestry of different agencies at the federal level, as well as at the state and local level. And I think this is one of the lessons learned from the pandemic: is we need greater clarity of accountability, greater clarity over decision making, whether that's at the federal level, or at the state level, or at the local level. And I hope this is one of the things that's going to be coming out of the pandemic is a sense of urgency to clarify that, because we need to start preparing for the next pandemic, even as we're trying to finish the one we're already in. We have to have a sense of urgency over preparing. It's just a matter of time.
Which brings me to my last question. A company like Genentech, if you can choose the key priority, the key way you'd like to adapt for the next pandemic, what is it?
Well, I think it's going to be, you're asking me to focus on one, and I would, I would say, it's partnerships, a sense of urgency, but I think it's this preparations and partnering with the government around preparing for the next pandemic, making sure that we have manufacturing capability, capacity, making sure we're investing in the sorts of research that's going to be critical to provide the base technology to allow us to respond to whatever that threat is, and to make sure we've got enough product available to be able to respond quickly, that we've got a diversified strategic national stockpile, that whatever the threat is, we can rapidly address it.
Alexander Hardy, thank you so much for joining me at Washington Post Live.
Thank you, Francis. It was a pleasure to talk to you. Take care.
Thank you. I'll be back in a few moments with the Chicago Health Commissioner to see another side of our preparations for the next pandemic.
The toughest of times brought out the best in us. And thanks to the collaboration between our scientists, the government, and others, each day millions of COVID-19 vaccine shots are protecting us. But we still face challenges, which is why America's biopharmaceutical scientists are working to combat variants, find new treatments, and make as many vaccines as the world needs. So while you do your part, we'll continue to do ours. Pharma, our work continues.
Hello, I'm Suzanne Kelly, CEO and publisher of the Cipher Brief, a media organization focused on national security. We all know that the COVID pandemic impacted every part of our lives, but it also presented incredible opportunities to learn, to adapt, and to grow. And I wanted to talk a little bit more about that today with Pharma President and CEO Stephen Ubel. Mr. Ubel, thank you for joining us.
Thanks, Suzanne. Great to be with you.
You know, the biopharmaceutical industry really responded to COVID-19 in a robust, collaborative way that produced billions of both vaccines and treatments. What have you learned along the way that may help with future emergencies?
Well, as you point out, addressing the pandemic was really the industry's finest hour. It's very difficult to create a new class of medicines. It's a medical miracle, frankly, to do it inside a calendar year. You know, if you reflect back to the beginning of the pandemic, we actually had very little to offer physicians who are treating patients with COVID-19 to where we are today with 9 authorized and approved vaccines and treatments, which has really enabled us to save countless lives and return to relative normalcy. And we've learned a lot over the past couple of years that we think can be leveraged going forward. I think there are really 3 key takeaways. The first is collaboration. There was an unprecedented level of collaboration with key public health officials at the state, national, and international levels. You know, at the beginning of the pandemic, we had lots of interaction with government officials around how to ensure that clinical trials were as efficient as possible. We tried to look ahead and identify bottlenecks in the supply chain to ramp up production as quickly as possible without jeopardizing access to inputs that are critical for manufacturing other medicines. And perhaps less appreciated is the unprecedented collaboration within the industry, as we saw numerous instances of our companies checking their competitive nature at the door and helping their competitors manufacture life-saving vaccines and therapeutics. So Merck, for example, helping to manufacture J&J's vaccine, or Amgen helping to manufacture Eli Lilly's monoclonal antibody, just to name a couple. Second, new technologies had an enormous impact, whether it was new technologies to help decode the virus in record time, or digital technologies like telehealth or remote monitoring technologies that help clinical trials continue in an environment where patients were not going to see their physician or visiting the hospital due to social distancing requirements. And we think there's great potential going forward to leverage those technologies to further decentralize clinical trials and address lack of participation in those trials, particularly among underserved Black and Brown communities. Stay tuned on this. We'll be announcing significant new efforts on this front in the coming weeks. Third, many patients who sadly died of COVID have actually died from secondary infections, which there are no effective antibiotics. We think there are steps Congress could take, namely by enacting the Pasteur Act, which would provide for novel contracting approaches like subscription models to address the fundamental challenge in this space, which is that it's very challenging to invest billions in developing new antimicrobials that by definition we want to use in a more limited way.
Yeah, and I think, you know, one of the big technological advances clearly has been the mRNA platform technology. How has this been sort of game changing for the industry, do you think?
As you point out, it is a platform technology. It's been in development for decades. It was initially studied to help develop more effective flu vaccines, as well as for Zika and other public health threats. You know, the technology is pretty amazing. It basically allows us to instruct the body to create a harmless protein that is associated with a disease, like the spike protein as a part of the COVID virus. That triggers our own body's immune system to recognize it and attack it if it's ever present in the body. The platform also allows us to deal with mutations much more quickly than previous technologies. So as you point out, it's a very exciting technology. It's now being studied in clinical trials for other diseases like HIV, as well as other types of cancer like melanoma and pancreatic cancer, for example. And I must point out that it's really our ecosystem in the United States that led to the development of mRNA. It's the envy of the world. And candidly, it's being jeopardized by policies that would, for example, impose price controls on the industry or other steps that would chill investment going forward. So we think there are better ways to lower costs for patients without sacrificing access to future treatments like mRNA.
So much of the discussion this last 6 months and even a little bit longer than that has been around supply chain. How is the industry navigating those issues?
Our industry has a very robust, diverse, and global supply chain that's really enabled the industry to address COVID-19 without major disruption. You may remember several years ago, there was a major hurricane that devastated Puerto Rico, which is a manufacturing hub for the industry. But due to the diverse global nature of our supply chain, our companies were able to redirect various aspects of the manufacturing process to other locations, and we didn't skip a beat. And we're on track today to deliver 20 billion doses of vaccine, largely because of this global diverse supply chain. Having said that, there are certainly ways to enhance the resilience of the supply chain. We should make it easier for competitors to team up, as I described before. New creative partnerships should be forged around the world to voluntarily share technical know-how. Some have argued that breaking patents and essentially giving away our intellectual property is the way to go. We think that would be a big mistake. The main issue with global access to vaccine today isn't supply. It's a host of other issues we need to work with stakeholders on, like vaccine hesitancy and ensuring the local health infrastructure necessary to effectively distribute products. Some have also argued that we should take steps to bring more manufacturing to the United States. We, of course, support more incentives to do that, but we should do so in a targeted way so that we avoid policies that might exacerbate the problems we're trying to solve by creating shortages or increasing costs for consumers unnecessarily.
There's so much more to dig in on here. Thank you so much for taking the time to chat with us for a few minutes, former President and CEO Stephen Ubel. Now back to the Washington Post.
When I think back on COVID, January 2020 is when I formally became the commissioner. And 4 days later is when we activated for COVID here at the health department. I was familiar, certainly, with CDPH and had been working in the emergency preparedness and the infectious disease and the outbreak space. So in some ways, this response was something that I personally, and really the department, had trained for and prepared for years and years and years. But we know that really outside of public health, there was perhaps not this level of awareness or preparedness. And so when I think back first on something that I think was a success, but also sort of a challenge going forward, is that we really were here in Chicago, it turned out, from a preparedness standpoint, in a remarkably better place than most other cities were.
Welcome back to Washington Post Live. For those of you just joining us, I'm Frances Steed Sellers, a senior writer here at the Post. I'm delighted now to welcome Dr. Allison Arwady. She is the Health Commissioner for the City of Chicago. Dr. Arwady, a very warm welcome to Washington Post Live.
Thank you for having me.
Having a little trouble there on sound. Maybe.
Are you hearing me now?
Yes, I've got you there now. So welcome to Washington Post Live. To our audience, please don't forget, if you would like to send in questions, tweet them to @PostLive. That's @PostLive. So sorry for that little hiccup at the beginning on the sound, but my first question to you is about what we heard in the video. 4 days before you activated for COVID, you became health commissioner. Tell us about the whirlwind that must have been.
Yes. So luckily, I had been at the Chicago Department of Public Health since 2015. I have a long career in outbreak response. It's my area of expertise. But nevertheless, I'd been the acting commissioner, but I was confirmed just 4 days before. And we started screening at O'Hare. And then just, within a couple of weeks, had what turned out to be the second case of COVID in the US and the first case of confirmed person-to-person transmission. So right away, really thrust into local, state, and national conversations about what our response was, and having to talk a lot about the preparedness measures that we did have in place. And just to kind of start it off, so glad everything we had done in advance we had in place. And when I'm looking ahead, it's about building on a lot of the strengths that we had here and recognizing where we didn't have things that it turns out that we really needed in Chicago, but also as a system.
So tell me about those strengths. I mean, Chicago is a big city with a centralized health system. Talk to us about what Chicago had and how that compares to this very diffuse public health system in the country where, a state like North Carolina has 100 separate health departments.
Yes. So we have lots and lots of health departments across the state of Illinois, but we work together. And here in Chicago, in particular, as a big city, we'd been receiving some emergency preparedness funding from the federal government going all the way back to 9/11. That's really when we started thinking about what does it mean to be prepared for bioterrorism? What does it mean, after anthrax, et cetera? And I have to give my emergency preparedness team in Chicago enormous thanks and gratitude for being as serious as they were. The year prior to COVID, when I was not in the commissioner role yet, but here, we had actually focused on pandemic preparedness. I had imagined, what if we had a big pandemic influenza outbreak? We modeled out an outbreak that would have looked like 1918 here in Chicago, and we modeled out one that would have looked like H1N1, and we modeled out one that showed up kind of in between those two, which is where COVID landed. And we did a full city activation where we got the schools together and said, what if we had to close and we had to feed all the kids? What would that look like? We updated all of our plans. We had all of these annexes around, here's who the partners need to be, here's what we would use. We'd practiced using our mobile morgues we had stored. We had millions of pristine N95s ready to go for the healthcare system. I wish that across the whole country and at the federal level, everybody had taken the stuff of emergency preparedness as seriously as we did in Chicago. Because let me tell you, knowing that we had some of those material resources, we had some ventilators, we had PPE, we didn't have it for everybody. We were really, what we'd been funded to was to support the acute healthcare system, the hospitals, but we were needing materials for outpatient. We were needing materials for long-term care. We were needing materials for the general public. And that was not something that the health department had previously planned for or been funded for. And I think the stuff part, though, is, we had that just about as right as anybody did in the country. And yet there were so many gaps where you think about the systems and especially the personnel. And so in the same way, we were very serious about investing in the infrastructure, the warehouses, the training. Every time we have the marathon here or Lollapalooza, 17, 18 times a year, we activate as a city like it is an emergency response, and we practice that with everybody. What we need, though, is more of the boots on the ground, frankly, doing the work of public health all the time that can then very quickly transition in an emergency. And having some of that core is what we've invested in, because we had a lot of the stuff. We were able to invest more in the personnel. And I really want to be able to hopefully keep that kind of preparedness up, where you're hiring folks from neighborhoods, building trust, building that infrastructure, because that was the piece that we didn't have enough of, frankly, right at the beginning. And although we've built it up now, I am not sure that we will be receiving the funding long-term to sustain it, and we need it.
But a city's not an island, which is really where I was going with this question. You're in the state of Illinois, huge political diversity in that state. How have you worked with the other public health departments in the state? What have you learned from them? And what has Chicago had to do to help? You have many of the biggest hospitals in the state.
That's right. Yeah, we are very much the regional referral center. So when you're thinking especially about that specialized care, or you're thinking about some of the smaller hospitals downstate being overwhelmed, and even outside of Illinois, we know that a lot of patients are transferred to Chicago. And, I was very proud of our healthcare system here. I have to tell you that in all of our planning, we had not seriously anticipated overrunning the health system like we saw happen in parts of the world and the US. But the good news is we did already have some systems in place so that we had a citywide and even a statewide view of where there was bed capacity, where there was ICU capacity. And a lot of our hospitals stepped up in amazing ways to say, we will transform whole sections of our hospital for higher level ICU care for people who need it for COVID, even if the financial reimbursement is not really there, especially for folks who, may have Medicaid or be uninsured. But it is true that we end up getting having to provide a lot of that higher level care for the whole region. And so thinking about some of those transfers, of course, working with the Illinois Department of Public Health and with all of, especially the Northern Illinois Public Health Consortium, sharing resources, trying to make sure we're aligned on messaging, working to build that trust, and thinking about, mutual aid where that is possible. I think as a whole country, when different parts of the country were surging, we saw the ability to transfer additional, doctors and nurses and public health staff to an area that needed it in a short-term way. And thinking about that mutual aid idea across the whole country makes some sense. But if you're in the middle of an Omicron wave and the whole country is getting slammed, you again have the potential to really outrun that fairly quickly. So yes, everything in public health by definition is collaborative, and we really think a lot together. I think about equity and how do we together make sure that we are lifting up access, whether it's here in Chicago, in Northern Illinois, or even across the country. How do we think about decreasing the barriers of access to care, to vaccination, and take lessons learned from one part of the state or the country and try them here in Chicago and vice versa?
So let me ask you about the federal response. The Global Health Security Index ranked the US #1 in preparedness, and yet we're around 1 million deaths now, and the US has been widely criticized for health inequities. What do you make of that disconnect, and what can Chicago do to help rectify it?
Yeah, so I think I've been impressed, honestly, that the people who work on this have taken such a clear-eyed view and said all of the things that we thought mattered the most for preparedness turned out to not be the things that mattered most. So that's where I said, we had this stuff, and yes, you have to have that. But what does it look like, and how do, some of the most interesting papers around that, I think, are measures recognizing that things like trust, interpersonal trust in government, lack of corruption in government, if you can have improvements in those, which sometimes, we think of as softer things to be able to measure, some of the researchers were able to show that really countries that had higher levels of trust in each other and in the government have had better outcomes, at least to date in COVID. And so much of our response has been highly politicized here that I think trust has gone down. And I've certainly spent a lot more time thinking about how you build trust, how you combat misinformation, how you think about who the messengers are. I also think, frankly, it's highlighted the ways in which we are not a particularly healthy country at baseline in the US. We don't live the longest. We have a lot of chronic diseases. We've seen that a high body mass index, more obesity, is an independent risk factor for poor COVID outcomes, not just at the individual level, but likely at the country level. And so when I think about us being prepared as a country, yes, it's all the infectious disease work, but it's also, can we invest in a way that actually improves health at baseline, that makes sure people are less likely to develop the chronic diseases that put you at risk for the severe outcomes of COVID or anything else? And how do we actually, build health at baseline? Not just health care, which is sort of the repair shop, but how do we make the public health, the environments in which people live healthier and actually improve the health of our population. Because the other reason that we were hit hard, I think, is just that we are not as healthy at baseline.
So if there are problems with trust, and I think they've been really very well documented that you're describing with the federal government, federal levels, every level, I think, in delivery, what about one of the great successes, which is the biotech area, the invention of these mRNA vaccines? What does that say about the relationship with private practice and with the federal government, and how public health fits into this?
Yes. So, amazing the way biotech, we know this is a strength in the US. It's something we have invested in heavily as a country. It's something that certainly there are market forces that can drive, if it's set up well, this kind of innovation. And it is amazing to me how quickly that technology really came to bear fruit. And thank goodness, right? The most important thing. However, I always remind people, even in the year 2020, the year the pandemic hit us, if you look at US spending, our health dollar, $4.1 trillion that year, what percent do you think was spent on public health activities in year one of the pandemic? 5%. And that's per CMS, Center for Medicaid and Medicare. And if we're only spending 5% of our health dollar on all of the preventive activities, and that's not just for pandemic, that's our behavioral health work, that's our environmental health work, that's our food protection work, that's our maternal child health work. You end up seeing that, of course, we've got these amazing outcomes, and we should be so proud of them. But how do we take that innovation and how do we take that financial support into the public health space, which is all about delivering that technology to people in an equitable way, right? Even when we had these amazing vaccines, we have these amazing treatments available, we still see people in parts of Chicago initially unable to access them. Now we've done a lot around, you can get a vaccine at your home, no matter who you are, any age, booster. We started that and we've continued it to help with the access issues. But again, back to sort of trust and understanding who is the messenger and is this technology for me? What was the research done on people who look like me and share my experience? Is this something that I actually believe will make my own health and my family's health better or not? And we just have not invested in the infrastructure of building that confidence and of creating, I think, the pipeline of not just developing these amazing technologies for well-insured people, but how to make sure that, especially in a crisis, anybody who needs these can access them.
Are we even having those conversations? Are you speaking to biotech companies and telling them how important it is to get a diverse group of people into clinical trials and pregnant women? Are you having the conversations with the federal government to make sure this triangle is, the parts of the triangle are held together?
Yeah, certainly. I think on the clinical research side, for example, here in Chicago, I think obviously we participate in our academic health centers and our researchers participate in a lot of these trials. And we have put a lot of effort into improving the racial and ethnic diversity and all other types of diversity in these trials. There's a long way to go, but I was really pleased, for example, that when we were sharing the initial vaccine trial data, I could point out this is who participated in these trials in Chicago, and this is what those people look like, because we did have much, much higher than national standards for how many people, especially Black and Latinx folks, were participating in Chicago. Still not enough. But I think having these conversations, and we've tried at some level to broker these where you're saying, the secret sauce is often in who is doing the asking, who is doing the explaining. And I think we've tried some innovative things here and continue to try to learn from examples at the health department and with partners about how do you extend that and build that. But it's not something that has historically been as seriously investigated, I think, as the scientific side has. And we are part of conversations on that, and we think it's critical. And I think we've seen it was so unusual. Still, a year plus after we've had a vaccine, I still have to reassure people that they will not get charged for a vaccine. regardless of their immigration status, their income, their insurance status. It is so atypical for people to be able to get even these preventive measures without worrying about a bill, that we have to change that paradigm, so that especially the less expensive, highly preventive opportunities for people to access that technology are trusted, available to all.
Tell me quickly where things stand in Chicago after the Omicron wave and now with these subvariants appearing to threaten us.
Yeah, so the Omicron wave actually hit us very hard, the initial Omicron wave in Chicago. We had more Chicagoans hospitalized during the Omicron wave than at any point prior. And most of those folks, many of those folks were not vaccinated still. And this gets back to although we've done a lot on this and I'm really proud of it, there are still people who have not chosen to take advantage of that technology. We have, just Friday, we moved from that low COVID-19 level into the medium COVID-19 level. That's not because of severe outcomes, but it is because we are seeing more and more cases with these subvariants coming. So we are back to, again, strongly recommending masks in indoor settings. And we've said if we get to the high level, we would require them again. I hope we don't get there. We're not close to getting there right now. But it is a moment where we're paying some attention again to COVID. And nobody wants this to be quote unquote over as much as I do. But I think it is about learning to live and moderate risk depending on what the risk is in the community. So I'm confident about the systems that we have in place. I'm confident about how our health systems are working together, a lot of the infrastructure we've built up here in Chicago. I'm confident, under Mayor Lightfoot, all of the focus that we've put on equity and continue to learn lessons from that. But COVID is on the rise again here. So we're keeping a close eye and continuing to work on both the direct and the indirect effects of COVID, which I think continue to really show up in all kinds of new and concerning ways.
I want to squeeze in one last question, so we're running out of time, but looking ahead, either to a very different new variant of this particular pathogen or an entirely new one which could affect very different populations, pick one or two key lessons, and I'm afraid it has to be quick, that you take from the experience you've had over the last 2 years that'll be key. Response.
Yeah, key lesson is do what we did here in Chicago. We hired about 800 Chicagoans from our west and south sides, more than 90% Black and Latino, with no prior educational or work experience. They just had to be good at talking to people. We hired them to be our contact tracing team, and then they became our vaccine ambassadors. And now they're connecting people to treatment and to care. And being able for me to have a sustained workforce that is through community-based organizations, so that we also have 30 community-based organizations that all together have a network. They see themselves as part of public health. We grow and train folks without barriers to entry to become that public health workforce. And we need to sustain that workforce long-term and have it be flexible. So no matter what comes next, they can convert from working on diabetes or heart disease or food insecurity. They can convert quickly to any emergency preparedness response for which they would be needed. And that for me, it's not just about the stuff, it's the systems and the personnel to build it. And that's probably our biggest lesson here in Chicago. Trust the folks who are on the ground, train them, and build that human infrastructure, and don't just fund when a pandemic comes, fund long-term so we can build that infrastructure, make us a healthier country at baseline, and be able to build on the successes we've had in Chicago and respond even more effectively.
We heard that loud and clear, a message for a sustained human infrastructure. Dr. Allison Arwady, thank you so much for joining us at Washington Post Live.
Thank you for having me.
Thank you also to our audience. If you want to sign up for our future programming, go to WashingtonPostLive.com. You'll find lots of interesting stuff to come. Thank you for joining us today. I'm Frances Steed Sellers.